So hello and welcome to our endocrinology case study. My name is Samantha Christie.
My name is Alexis Hernandez.
And we're going to go ahead and jump right in. So a little bit about our patient and their symptoms is he is a 42-year-old male who entered the clinic with complaints of general fatigue, loss of libido, and as well as erectile dysfunction for the first time.
As for his medical history, in 1999, the patient was injured in a traffic accident, which left him suffering from severe pain due to a left brachial plexus injury. Due to the severe pain, physicians prescribed him with transdermal fentanyl starting January 2011 and had been increasing the dosage over time. After 4 months of treatment, the patient began to notice his current symptoms, which brought him to the clinic.
So upon admission, the patient was within normal ranges of height, weight, BMI, blood pressure, heart rate, and body temperature. And further physical examination showed no significant findings, including Hercus and pubic hair. And radiography of the thorax, as well as an electrocardiogram, were all normal. And an MRI was also conducted of the hypothalamus and pituitary gland, which showed no abnormal findings.
Along with the physical examinations, they also performed a few lab test results. And in the morning of 8 a.m., the endocrine examinations of TSH, FT3, FT4, IGF-1, ACTH, cortisol, DHEA-S, and urinary cortisol were all within normal ranges. Although the patient's levels of LH, FSH, total testosterone, and free testosterone were all below normal ranges. Physicians then conducted a TRH, CRH, LH, RH stimulating test, and the test showed that the FSH reaction was delayed. And below, in the two tables below, you can see that the highlighted portions were all the abnormal test results.
So based off the information collected from the physical examination of the patient and as well as the lab results that came in, physicians were able to diagnose this patient with hypogonadotropic hypogonadism, which was caused by the chronic use of the transdermal fentanyl.
As for treatment for this particular patient, he was treated with hormone replacement therapy, specifically testosterone. Hormone replacement therapy was the best treatment for this patient, only because they had to remain the treatment of the transdermal fentanyl since the patient's pain was chronic and so severe that the regular analgesics such as nonsteroidal anti-inflammatory drugs, anticonvulsants, and buprenorphine do not control the pain.
So a little bit about the significance and importance of this is the suggested mechanisms that explain the opioid-induced hypogonadism is due to that both endogenous and exogenous opioids can bind opioid receptors in the hypothalamus, and opioids actually decrease the release of GnRH in the hypothalamus, which results in a decrease of LH and FSH release from the pituitary glands, and as well as testosterone and estradiol from the gonads. And patients with opioid-induced hypogonadism will have low testosterone or estradiol, which will be paired with either low or normal levels of LH and FSH. And concluding statements from the physicians include that with the rising prescriptions of opioids given for pain, it must be considered to conduct a routine screening for the endocrine dysfunctions in patients with chronic opioid treatment.
So that concludes our presentation. This is our reference case study, a case of hypogonadotrophic hypogonadism caused by opioid treatment for non-malignant chronic pain.
And thank you so much for listening. Goodbye.